get started. I think the meeting is already being recorded. And we realize that folks will be trickling in. So hi, and welcome to this rendition of our Chow Time webinar series. We're really in for a treat. We have a guest speaker today and are pleased to be presenting on chronic pain. My name is Rebecca Martinez. I'm a nurse practitioner with the Chow team. I function as a clinician trainer, and we're happy to see some familiar faces and some new faces on here as well. Feel free to rename yourself with where you're from, or stick it in the chat. We'd love to see who we have on the webinar today. So for those of you who have been with us before, we'll start out with a brief introduction to our team so that you can match the faces to the names and Zoom tiles that you're seeing. And then we'll launch into our case study and content for today, which is on chronic pain, and we'll be using a case study on chronic low back pain. And as typical for us as an academic detailing training unit, we'll be doing a demonstration of an academic detailing visit so you all can see how these topics might come up in the real world in a conversation between a detailer and a provider. Questions and answers will come at the end, though we may certainly address some that come up in the chat during the live portion. So please submit all questions in the chat. We would appreciate that to be able to keep track. All right, so for those of you who are joining us for the first time, we are the Center for Innovation in Academic Detailing on Opioids. We work both with California Department of Health and the CDC to decrease opioid-related morbidity and mortality by promoting balanced approaches to opioid management. And we do this by collaborating with healthcare providers to improve opioid and chronic pain-related care through innovative training and technical assistance services. So we have a fun multidisciplinary team that both does academic detailing trainings, technical assistance, and we develop content as well around opioids and chronic pain that lives on our website. And I think our website will come up in the chat so that you all can check out what we have online. This is our current team. We have some new faces on our team as we've had some transitions in the last couple months. So let's go around and just give a brief intro. So again, I'm Rebecca. I'm a nurse practitioner, have had stints in primary care. I do a lot of HIV and hepatitis prevention work, and work as well in substance use disorder, in the field of substance use disorder management. Let me pass the baton to Brian. Want to say hi?
Hi, everyone. My name is Brian. I'm the program director. So if you want to reach out to us after this webinar to inquire about some of our services or the potential for partnership, I'll likely be the one to respond and to continue the conversation. So hope to speak with any and all of you afterwards. Thanks. How about Claire, our new program assistant? Would you like to introduce yourself?
Hi, everyone. Nice to meet you all. My name is Claire Schutz. I am the new research program assistant at Chow. Bunny, would you like to go ahead?
Yes. Hello. I'm Bunny. I am a new clinician trainer at Chow, and I also work at CISA. It's very nice to be here today. Thank you.
And I'm Philip Coffin, the medical director, and excited as always to be able to share this webinar with you all.
And today's guest speaker, I want to take a moment to introduce her, is Antje Barreveld, MD, and she is an assistant professor of anesthesiology at Tufts University School of Medicine, medical director of pain management services, and co-founder of the Substance Use Services, and is an anesthesiologist at Newton Wellesley Hospital. She's on the editorial board for Pain Medicine and chair of the American Academy of Pain Medicine Opioid Committee. She served as co-principal investigator of the Harvard School of Dental Medicine and Brigham and Women's Hospital Center of Excellence in Pain Education, COEPE for short, designated by the National Institute of Health Pain Consortium. She's an appointed expert to the ASRA Substance Use Disorder Working Group, and Dr. Barveld is a 2020 May Day Pain and Society Fellow. And we've been working with Dr. Barveld to develop more of our pain curriculum and are totally thrilled by her expertise and sort of the perspective that she brings to a really complex issue facing healthcare and all healthcare workers at this time. So we're really delighted to have her share with all of you some approaches to chronic pain management. So with that, our topic for today, chronic pain, and we're tackling chronic pain from a case study perspective, as we do in all of our webinars. The reality is that oftentimes clinicians feel like they're just barely keeping their heads above water to adequately address chronic pain and keep patients both happy and safe. So we believe that debunking some of these issues in chronic pain management for both academic detailers and healthcare workers alike can help all of us better advocate for patient-centered care and evidence-based practice in the communities that we work in. So whether you're a detailer, a clinician, or work for programs that are looking to reduce the harms of opioids in your communities, we've designed this webinar to have a little something for everyone. So with that, I will pass the mic to Antje. Dr. Barveld.
Everyone, thank you for having me. Does the sound okay, Rebecca? Great. So I work in a multidisciplinary pain management center and feel very fortunate to have a big team behind me. Not everyone in the United States, I see people from all over the country, have access to people with pain expertise. And you don't have to be an expert to manage pain. And I hope that today you'll get some practical tools for advising your colleagues on how they can safely treat pain and think about pain from a pain management perspective, one that I come from. So we'll start with Jack. Jack is a 57-year-old construction worker with a long history of chronic back pain that occasionally radiates into his leg and his foot. He's been using oxycodone. It's been helping him get through work, and his primary care physician has prescribed this to him in the past. He feels he needs more regular opioid prescriptions so he can function. How are we going to advise him on how to best manage his chronic pain? Next. I think we should start with basic definitions. Pain is subjective, and the International Association for the Study of Pain defines it as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. One person who may have an injury will potentially respond very differently than someone else. That doesn't have anything to do with how strong they are or perhaps how they cope with pain per se, but there are so many modifying factors that really influence our subjective experience of pain. Next slide. So pain is complicated. We know that there may be that injury that causes pain, and then when we look at our coping mechanisms, how the central nervous system is processing pain, and psychological inputs, and even stress that accompanies pain. What else might be going on in someone's life? All of these interact in a very complicated way, which doesn't mean that treating pain has to be complicated, but we have to understand all the different aspects to a patient's individual pain experience. Next. And understanding these pathways can also help us to implement certain pharmacologic strategies, for instance, as well as other non-pharmacologic strategies, such as mindfulness techniques, acupuncture, et cetera. These techniques and medications all work on different aspects of pain transmission. Next. I like to tell my patients who say to me, I've been going to my physicians, I feel dismissed, no one's really listening to me, people tell me that I'm crazy. And I say, well, pain is in your head. You are not crazy. Your pain is real. And that is because pain is a central nervous system challenge. And what we need to do is to help our patients understand that modulating the pain experience can be done and can be done from a central nervous system processing level. I like to tell patients that if I compare you with chronic pain to someone who doesn't have chronic pain and look at how your brain lights up in a magnetic resonance image scan, an MRI, your brain will look completely different and fires differently than someone without pain. So there are real measurable changes. We don't do this to measure pain in all of our patients, however. That would not be cost effective. But we know that we have to be able to think about our patients from that perspective, that modifying the central nervous system experience of pain is also part of how we can help them. Next. Another thing I like to tell patients is that these changes in your brain that actually lead to a decrease in your brain matter volume when accompanied by chronic pain, when you experience chronic pain, are reversible. So when you manage pain, these central nervous system changes can also be changed and modulated. Next. So why do we care about pain? We know that pain is everywhere. And back in 2011, the Institute of Medicine report really highlighted the fact that we may not be doing enough to care for our patients with chronic pain. And effective pain management is a moral imperative, a professional responsibility and duty of people in the healing professions. We have run into some major challenges when we think about managing chronic pain. And we know that education about safe practices in opioid prescribing initially had been lacking. Many of our healthcare providers really feel underprepared to manage pain, despite the fact that 20% of Americans live with chronic pain. Next. So why, again, is there such a huge impact on our society, on our economics, and on the individuals who suffer from chronic pain? Well, that is because there are all of those downstream effects on our physiology, our cognition, our emotional well-being, the way that we interact with family, and how we might be able to make a living and work. We know that if you have a lot of acute pain, you are more at risk of having chronic pain. And the way to manage pain is not just one medication or one surgery or one injection or just telling someone to sort of take a deep breath and deal with it. It's really looking at pain from all of these different angles and how we can support our patients. There is a role for opioids in managing acute pain, absolutely. In chronic non-cancer pain, it is, of course, very controversial. The one thing that we haven't done over the years, however, is to clarify that chronic pain is not the same thing as an addiction. And yet we cannot ignore the realities of what has happened with our opioid crisis. And so helping our prescribers and clinicians to understand the sort of physiologic mechanisms of pain and the individual patient experience can help us to come up with some different tools that our patients might benefit from for managing their pain, and not necessarily a medication or an opioid as a first-line treatment. Next. So let's go back to Jack. He's otherwise healthy. He has no personal or family history of substance use, and that's important in understanding someone who may have higher risk factors for misusing a medication, such as an opioid. And he has none of those risk factors. Next. So we'd like to do a poll. If you can please pick your answers here. Launch that. And I'll read the questions to you. If I don't see it, Rebecca, then I can read them out loud. Thanks for your patience. Give us one moment. There we are. So I'd like you to pick the best statement. So all of the following statements around opioid management of chronic pain are correct. So pick the one that is incorrect. Patients prescribed chronic opioid therapy often feel stigmatized. Opioids cannot safely be used for managing pain. Sorry, there's some words that are missing. Prescribers, and that should be managing chronic pain. Prescribers face regulatory fears surrounding opioid prescribing, such as DEA prosecution of prescribers. Opioids have historically been overprescribed in the United States. Opioids are more likely to be prescribed to white patients than Black patients. Thank you for submitting your responses. another 5 seconds. Last chance. Thank you. So the majority of you did pick the correct response, and we apologize again that the word fell off at the end there. We can go to the next slide. So opioids can be safely used for chronic pain, and many prescribers at this time really are worried about what it means to prescribe an opioid for chronic pain. How do I keep my patients safe? How do I protect my license? And yet to remember that there is no one-size-fits-all when we treat pain. And so although opioids are not first-line treatment for chronic pain, and we may not see long-term benefits in function for patients prescribed opioids, for certain patients, they can be really life-altering and allow them to function in a way that we can never imagine. Next slide, please. The one reason I think why we are also faced with a huge pain care crisis, in addition to the opioid crisis, is a continued provider lack of confidence and knowledge. And we must all understand that when it comes to managing chronic pain, most people in nursing school or advanced practice provider school or in going to medical school have not received dedicated pain teaching. Before 2017 at Harvard Medical School, where I teach, we didn't have a single dedicated hour of pain teaching. The lack of knowledge and confidence, as we mentioned in the poll before, is also influenced by this fear of my patients getting addicted. Or could I be prosecuted for prescribing medications to doses? So for all these reasons, and which I will highlight, there have been challenges around how we know how to manage pain and the knowledge that we actually have to do so. Go to the next slide. And thank you, Rebecca, for muting any others that might be on. Additional pain care barriers include, for many of our patients, the stigma. And again, this misconception that pain is the same thing as addiction. I have many of patients tell me how embarrassed they feel when they go to the pharmacy, how the pharmacist makes them feel, how people look at them when they pick up an opioid prescription. Or if they're sitting in the office and someone yells to them, "You have to give me your urine." How does that make the patient feel? So there really is a huge stigma around chronic pain and the fact that, again, pain sometimes is equated with addiction. Additional racial and ethnic disparities in pain treatment exist. There are emergency department and outpatient studies that actually show that patients with back pain, abdominal pain, and migraine are treated differently based on their race, so that Black patients are less likely to be prescribed an opioid for the same pain condition. There are even racist myths that are pervasive in medical schools. One survey from 2016 did a qualitative and quantitative study of medical students and residents' perceptions of pain in their patients. One student noted Black people's nerve endings are less sensitive than white people. On top of that, we have social inequities, geographic constraints, lack of access to multidisciplinary care, and insurance companies. Insurance companies make it very difficult for me to recommend certain treatments because the prescriber potentially, or the insurance carrier, does not cover certain medications, or really typically most non-pharmacologic approaches come also with a lot of cost to the patient, co-pays that they need to pay. So these financial barriers make it very difficult for us to provide the multidisciplinary care that we would like to. Next slide. And let's look at the fact that, again, there is fear and concern about prescribing opioids. And as we see this pendulum swing in pain management, what are we doing for our patients instead? How are we preventing transitions to illicit substances, as some states even are mandating maximum doses of opioids that someone can be prescribed when they may not have any medication misuse concerns or be overtaking their medications or be doing anything that really is of concern. They have been prescribed high doses of opioids over time. There is no reason that we need to blanket taper all of our patients. And yet this is unfortunately what has happened over the last few years. Next. So here we are in a pain care crisis, but that doesn't mean that there isn't something we can't do. understanding pain and really decoding what these strategies are that we can counsel our patients and providers on is what's going to make the difference. Pain care can be hard because patients are suffering, but with compassionate, informed principles, we can, again, make a big difference. And we need to individualize our approaches to pain care and really advocate for equitable pain management and access to the services that our patients need. Next. So what about Jack? So we know that he's a construction worker. He's been taking oxycodone. It's been helping him to make it to work. He's been having a hard time sleeping because of his back pain. So if he cannot work, he cannot support his family. He knows there are risks with opioids. He's not worried about them. So how are you going to assess his pain and advise him on what he should do next with his medications and other strategies for managing his pain? Here's our second poll. Thank you all for answering. And this question will be about pain assessment strategies. There we are. So all of the following are appropriate tools for assessing pain, except, so another one, which one of these does not fit? So how can we assess our patient's pain? A numeric rating scale, verbal descriptors, the pain story, current opioid misuse measure, the PEG scale, or the physical exam? Which one of these does not fit? And again, an emphasis on there's many ways to assess pain, and there's certain tools that we can use that give us quantifiable measures, and then there's also, of course, qualifiable measures of measuring pain, so not necessarily a score. All right. And let's go to the next slide. So the majority of you answered correctly. The current opioid misuse measure, if we go to the next slide, thank you, is actually a tool that's very, very useful for monitoring for challenges with an opioid medication. So for instance, there's questions about that may give you a little bit of a sense that there could be an issue. So could the patient have cravings for the medication? Are they having more obsessive thoughts about the medication? And so it's a subjective tool, however, very useful for us to be looking for patients that maybe could have some quote unquote red flags when it comes to using their opioids, but it is not a tool to assess pain. If we go to the next one, best place to start is really to encourage the patient's pain narrative. Sometimes all I'll do is sit down for even just 30 seconds of not touching my computer, letting the patient know who I am, and this must have been a really long, hard journey. I'm so glad you're here today. Tell me exactly where you think your pain is coming from, or how would you like to start today? And so in my mind, I'm always organizing their story, so I may ask them probing questions to really get to some key matters. Onset. When someone says, on June 2nd, 2020, I was doing this, and this happened to me, there was a moment in time that tells me a little bit about the mechanism of injury. Or someone might say, well, I haven't been feeling well for many months, and it started to get to the point where I couldn't sleep, and last winter was really horrific for me. So those clues can tell you something that may have occurred at that moment to start off the pain. And what makes it better? What makes it worse? If pain is constant, that's very different from someone who will tell you, well, I only have pain when I sit, or I only have pain when I walk, or only when I lie down. Those give me very important clues, especially when it comes to back pain evaluation. Describing it. Is it an ache? Is it sharp? Does it feel like a spasm? Is it like shooting pain down the leg? Also gives me clues as to where the pain generator might be coming from. And where is it? I always ask my patients, can you point to it? They may tell me it's my sciatica, but they may actually just be pointing to their hip. Or they may say it's my hamstring and be confused with sort of what's a gluteal muscle versus a hamstring muscle. So having patients point to the area of pain can be very helpful. And where does it travel? How bad is it? Function and pain interference are really the key things about assessment. What are the things that the pain keeps you from doing? Despite the fact that someone can work, can sleep relatively okay, can take care of their family. It doesn't diminish the impact pain is having on them physically or emotionally. However, it does tell me a little bit more about how they're doing day to day. And again, timing, is it a different time of the day? And does it feel different than previously? So OPQRST can be a helpful mnemonic for informing our clinicians on how to think about pain assessment. Next slide. So these are some clear tools that we use. I know that the numeric rating scale is something we've always historically used. Don't forget that's a static moment in time. Patients with chronic pain always live above a 6 out of 10 of pain. So that is not helpful to me at all. I actually do not. The only reasons that I sometimes record it is because it's required of me to report it to insurance companies for authorization purposes. I find it completely useless. However, what's more useful clinically is looking at these functional scales. There's different ones that are available. I listed some here. Also, the PEG-3 is one that CIAO uses, and that's in some of their education materials. And so finding what might work for a provider, and of course, looking at the physical exam, observation of the patient, their vital signs, all of these can be very important in informing how the patient is actually doing. Next. So back to Jack, his physical exam. So he's been having back pain going into his left leg. Actually, pain is primarily when he does sort of what we call facet loading maneuvers. So he turns and spins and leans back, and that really puts a lot of pressure on his back joints. He's not getting any shooting pain into the legs. Other physical exam maneuvers do not reproduce that leg pain. And so it seems that where his pain is coming from is really more from arthritis in his spine, or what we call spondylosis or facet arthropathy. So what are the best next steps that we can do to manage Jack's pain, also knowing that he's physically very active at work, and that's been making it difficult for him to function? Next. Here's our third poll. What are we going to do next for Jack? What would you do? Them otherwise. I haven't seen it pop up yet. So here are the options of things that you can do, or you can advise Jack's primary care provider for managing his chronic low back pain. So would you, number one, prescribe oxycodone and have him sign the opioid agreement? We know that it's helped him with his pain. Start non-steroidal anti-inflammatories such as ibuprofen. Refer him to massage or acupuncture. Or 4, collaborate with the patient on a multimodal care plan. Give it 2 more seconds, Rebecca, if you happen to have that come up. Great. So if you can all please pick one of those. So again, the first one is prescribe oxycodone and have him sign an opioid agreement. So which one is the best next step? Start the anti-inflammatories, refer to massage or acupuncture, or collaborate with him on a multimodal pain care plan. Great, we can finish that, Rebecca. So you all chose collaborate with the patient on a multimodal care plan, and I think all of these responses are potentially correct. And I would say that the best one, though, is to really work with Jack in saying sort of what are your goals? Besides oxycodone, what are some of the other things that we can work around on? And that can be a difficult conversation to have when he's very focused on saying, okay, this has worked for me, so that's what I want to do. And we can talk to him, however, about, well, there might be some other things that you haven't actually thought about. What are some other things that you might be interested in managing? Go to the next slide. So managing chronic non-cancer pain, I always talk to my patients about these different, we can call it the pain wheel, or we can call it sort of our different buckets of care. So one of those might be medications, another perhaps procedures, interventions, or surgeries. Others would be physical therapy-based exercises, integrative or complementary and alternative medicine techniques. Behavioral therapies can really be paramount as well. And I would not emphasize any single one of these. I tell my patients that we have to throw the kitchen sink at your pain. It's not going to be one thing that's going to take care of all of the pain that you feel day to day. Next. So giving our patients a menu of different options sometimes can be a bit overwhelming, where they come to you thinking that they're just going to get a prescription, and then all of a sudden you start talking to them about cognitive behavioral strategies. So how we word these things and how we provide this menu of options to our patients can be tailored to the type of pain they're experiencing, but also, again, be individualized to sort of what they're looking for. Someone may say, well, I don't have it, my insurance doesn't cover acupuncture. I have no ability to afford that. That would not be something that I would recommend to someone who does not have the financial means to do so. Next. So being systematic about how we think about pharmacotherapies for pain can help us to understand, okay, what those options are, and I'll briefly review different medications that you can use for managing chronic pain for different types of chronic pain. We also just want to check in with our patients and make sure they're not having side effects, and counsel them on non-pharmacologic options. So medications really are not always just the answer. So when should we consider opioids? That's always a challenging question, and I'm not sure that that's something that we can sort of cover today. However, we do need to explore all of the non-opioid options first and maximize those different multidisciplinary approaches so that we can give the patients the best chance of really improving day to day. So the type of my patient's pain may help me to understand a little bit of sort of some of the pharmacotherapies that might help outside of opioids. And for Jack, we know that there is somewhat of a neuropathic component because he has the shooting pain down the leg, although we did not have that reproduced. There was no other neurologic findings during his exam. But he really has a lot of musculoskeletal pain. Arthritis can be extremely painful. And when we think about arthritic pain, usually it is more well localized, but there can be a referral pattern to it. Someone who has facet arthropathy like Jack, they often will also describe that the pain radiates to their hip, which can sometimes be confusing if this is a hip pain syndrome or if this is spine. However, with imaging and other modalities, sometimes even diagnostic injections, we can help to localize where the pain is coming from. I wouldn't use a medication for nerve pain, like an anti-seizure medicine, if it's somatic pain. I have a patient who recently was referred to us for consideration of gabapentin. His pain, however, is orthopedic pain, musculoskeletal pain from the hip. And starting someone on a anti-seizure medication really would not be effective. And also, some medications come with significant side effects. In this case, my patient is morbidly obese, and putting them on gabapentin would really not be a good idea, given the fact that it can cause weight gain. So here's a little list, and we'll go to the next slide. And sometimes it's easier to also be thinking about medications by class and not just the type of pain and what medications would apply to that type of pain. And here's sort of a list of those different medications. Again, medications are a small piece of what I do in my clinical practice. It's one of those 5 pain wheels, and my focus is really not intensely on that. And there's many other ways that we can counsel our patients on integrative pain management strategies. And we need to be very cautious about the medications we prescribe. Non-steroidal anti-inflammatories can be excellent for musculoskeletal pain, but have potential for severe cardiac downstream effects, so they can really not be good for patients with underlying heart disease or high blood pressure or kidney disease. Patients can actually have worsening renal function or kidney failure when they're taking non-steroidals, in addition to the stomach upset that comes with non-steroidals. But what about a topical non-steroidal, such as diclofenac? In a thinner individual, that could potentially be very helpful. There can be absorption locally, and although there is some absorption throughout the body, it really does work more on the area of pain. So all of these have their benefits and drawbacks. And so when we're thinking about non-opioid options for pharmacotherapies for chronic pain, we really need to weigh the risks and the benefits of each of these. Next. So we discussed Jack. We discussed with Jack his pain care plan, and really open up the treatment strategy to more of that treatment wheel. So we talk about occasional opioids for severe pain. So I might ask him, how many do you think you need in the month in order to be able to function and be able to go to work? I also don't want him to injure himself at work. So even simply 2 to 3 sessions, well, he says my copay is $75. Well, then I'll say, if this is feasible for you, I would really like to help you keep working for longer. And if we put in this time for these sessions, you will have some strategies for preventative measures at work so that you do not injure yourself. And so helping him to understand that this is important for his movement and his ability to function is to also do it in a healthy, safe way, and physical therapy can guide with that. Non-opioid medications could be some of those topicals, some of the anti-inflammatories at times, making sure he doesn't have any contraindications or side effects. Vitamin D, very important for preventing a progression of bone disease. We might think about massage. TENS units are these little electrical pads that you can put on the skin, and they provide this transcutaneous neurostimulation, I believe is what it stands for. So basically, it can be distracting. It doesn't usually provide long-term relief, but can provide some of that short-term relief to really get someone through an activity that might be uncomfortable, such as sitting in the car for a while or doing some physical activity. There are some injections that can be very helpful. We don't like to put too much steroid in our patients, but for the case of arthritis from the spine, there are actually some radiofrequency treatments that are very common in the interventional pain world that could be helpful. Working on his sleep hygiene, what are the things he's doing before he goes to sleep? Is it just the pain that's keeping him from sleeping, or there's some other modifying factors that we can do, such as perhaps alcohol use at night, or too much screen time, many other sort of different things that we can work on with our patients around sleep hygiene and perhaps some relaxation mind-body strategies to help with sleep. Next. So pain management should be patient-focused, and making sure that we assess our patient's pain, look at what is the impact the pain is having on them from a day-to-day basis, whether it be physically, emotionally, and also in other aspects of their life, their job, their career. And having the patient part of that pain plan and getting them engaged in the next steps will help to make it successful. And it may not happen at that first visit. It may take a few visits where we focus on safe opioid prescribing one visit, and then the next visit we talk about some of the other aspects of pain care that we need to emphasize. And looking on these our functional outcomes for our patients will help us the most, not looking at a pain score or how the patient tells me, but really, are there tools that we can implement to really show that our patients are making some improvement with these individualized plans? Next. So when I think about my suggestions to Jack, I'm going to be talking about the non-opioid and occasionally when an opioid might be appropriate. What are the behavioral strategies that he might need? He doesn't have a lot of stress and anxiety, but having chronic pain day to day can be exhausting. It affects every aspect of you and also can make people very irritable. Again, the sleep deprivation is really hard. So sometimes some different pain coping strategies. There are lots of online resources if behavioral psychologists with an expertise in pain are not available. Most of them do come with a cost, a fee, some much more affordable than others, and I'm happy to share any of those resources with others. Don't forget about physical therapy, exercise. We didn't even touch upon diet, but food can have a big impact on pain as well. And our patients will vary individually in how they respond to the therapies that we recommend and the side effects of any medication. So monitoring for analgesia and side effects is also important throughout this whole process. Next. So what are our key messages? Always we want to think about non-opioid approaches in chronic pain management. We want to work with our patients collaboratively to be thinking about this multidisciplinary, multimodal strategy for pain treatment. We want to monitor our patients' function, help them to understand that living with chronic pain, we are not necessarily looking for a cure per se. We are looking for help with their day-to-day function. And patients with chronic pain often feel dismissed and stigmatized, and allowing them to tell us their pain story can really maximize the effect of our treatment and our patient-provider relationship. We want to keep our patients safe with opioids. We do not talk about those safe strategies, but those you can all access on the CIAO website. anything from potentially having naloxone at home, keeping their medications in a safe place, regular urine drug monitoring, and other measures, opioid agreements, regular visits to help keep our patients safe. Treating pain can be really fun, and some people ask me sort of, how can you do this day to day? Well, I don't do it 5 days a week because it is hard. However, when we look at non-specialists, it's not the majority of our practice and the majority of the patients we see typically, but it is a large part of our practice and regular care for our patients. When you see patients doing better over time, that reward pays off. This should not be intimidating. Next. I'll turn it back to Rebecca.
Thank you, Dr. Barveld. I see some little clapping hands. Thank you so much for sharing your expertise and your empathy. It's, I think a lot in pain management contexts, it's challenging because providers get into arguments with patients and patients don't feel like they're being heard. And so it's just really wonderful to hear your perspectives that I imagine make you a really phenomenal provider for patients who are living with chronic pain and suffering from chronic pain. So, so we're going to transition into and then I forgot to mention, if any questions came up from that presentation, or if you just want a little more detail on anything that Dr. Barveld shared, please put questions into the chat so we can keep an eye on them at the end of our time together.
I just wanted to interrupt really quickly. I just wanted to apologize to everybody. I just got to report that the polls were taking a really long time. Well, that's not news. You guys saw that they were taking a long time to launch, but you know, we were doing our best, and yeah, they just happened to be taking a while to launch. But we're hopeful that all the technological glitches are behind us now. So thanks.
Thanks, Brian. So now we're going to transition to an academic detailing mock visit, and Dr. Coffin and I will both be taking you through about a 15-minute, 10 to 15 minutes, let's say, conversation between an academic detailer and a clinician on this topic of chronic pain to see how these topics may come up in a one-on-one, peer-to-peer sort of setting with an academic detailing framework. So we've just put up on the slide the steps of the visit again. You can keep an eye out for how open-ended questions are used throughout the visit. Behavior change talk happens, and we'll make this short and sweet, and then have a little debrief at the end. I'm going to stop sharing my screen. I know some of you have your videos on, which is fine. We love to get to see folks' faces. It may help to put the Zoom into speaker view, or you can just pin videos as well, or just turn your video off if you don't want your face to be seen during this portion of the presentation. So Philip, start us off.
All right, it's just the two of us now. I do want to clarify that Rebecca and I don't have anything really clear in terms of how this is going to go. So there will be some surprise here, and it'll be a little bit like a real detailing visit. So thank you, Rebecca, for taking the time to meet with me. I wanted to check in first and see how much time we have.
Oh, you know, I'm trying to run off to a meeting that starts on the hour, so I have around 10 minutes, maybe 15 max.
Great. I'm going to set my alarm for 10 minutes so that I can make sure we certainly wrap up by then. So I'm Philip Coffin, and I'm part of a program that's working on meeting with providers and talking about opioid management in primary care. So my first question for you really is, how's it going with opioid management and chronic pain in your practice?
It's going, you know, like it always has. I've had a pretty large panel of patients who have chronic pain. I mean, I work in a rural area, so a lot of people have manual labor jobs. And I can't even tell you how many patients have low back pain, fibromyalgia, various forms of arthritis. It's definitely my daily bread to be talking with people about pain, but I'm trying to think if I have any particular issues. Not that come to mind.
Okay. And what do you do for pain management for your patients? Is it, do you have any sort of structure in place on how you manage it, or is it just kind of how people walk through the door?
A lot of it's how people walk through the door. I will use the physical exam and usual patient history to sort of identify my differential diagnosis for folks. We have a great physical therapy center that we work with, but not really great pain management referral options. So I find that often it's this back and forth with physical therapy. Patients will get some relief through doing physical therapy, and then they'll come back and then they'll have flares of their knee pain or whatever. So I do end up prescribing a lot of opioids, which patients want and they ask for. I spend a
That was
lot of
gonna be
visits
my next question.
refilling. Yeah.
That's going to be our next question. So yeah, I understand, that is the common issue, and that obviously is part of the reason that we're meeting today. Do you mind if I share my screen with you? I have some things that I think might be of interest.
Oh, sure. Go for it.
Great. So this is a book that we use, and I will send this to you, both a link and a PDF for it, when we're done today. But I wanted to share with you a couple of pages from it. The first page, which is something we also have as a poster. And are you able to read this, or do you need me to zoom in?
Maybe a little zoomed would help.
How's that?
Sure. That's better.
Great. So this is a table, we call it the pain wheel. Just has several options, and it kind of groups them. So because there's so many options, it can be really overwhelming. This kind of groups the options in different categories. So movement-based therapies, like the physical therapy that you send your patients to. Integrative therapies, which can be harder to access, particularly for low-income patients. Chiropractic may or may not be covered. Acupuncture, yoga, Tai Chi can be really extraordinary for some of those low back pain issues. And then behavioral therapies, because as we know, pain is a really complex phenomenon that, as a colleague of mine refers to it as, yes, it is actually in your head. And there is, the role of depression, anxiety, of psychological issues that may stem from the pain or may can otherwise contribute to the pain is really important to address. And then the procedures, and you might be a little bit limited without a pain clinic in some of the procedures, but there are things that you can do. Ice heat, TENS machines, which are actually really inexpensive now, and those are pretty easy and give some immediate relief for pain. And then a slew of different medications, with opioids being just one of all those options. A lot of our people we talk to end up putting this up on their wall as a poster to kind of help redirect patients away from always landing on opioids as their first choice. And then it goes into some detail down here as to all the stuff you need to do if you decide to prescribe opioids. And then opioid use disorder, which is, of course, a concern when prescribing opioids. Any thoughts about this?
I mean, it'd be nice if I had the time to do all of these and chat with my patients. It's like, yeah, I'm just thinking of folks who come in and really are sort of at their wits' end, feeling frustrated that their pain's not getting better. And so, yeah, it's just really hard to find the time because patients, they'll come in with their list of 5 or so things they want to talk with me about. And I like this, but I don't know how realistic it is for me.
Have you ever, do you ever set up a separate visit to specifically address pain?
I haven't. You're saying like having patients come back in and have a dedicated visit.
Yeah.
Hmm. I haven't done that historically in my practice.
Okay.
Are you all finding that that's a helpful way to make up some ground?
Yeah, actually, I think it's really critically important. There's a lot of things that you can cover in pain, and the other question is, I assume you have an EMR, Epic, or some other medical record system, and so in that pain problem, do you have how do you flesh out your pain problem? A lot of people now are including a whole bunch of different elements
Hmm.
to that
Like
problem.
like what?
Like the details about the pain itself. When did it start? How do they characterize it? um, what makes it better or worse? So you have that background, so you remember what the pain is, because you've got so many patients. Like lower back pain is not necessarily the same in every patient that you're seeing. Sometimes it
Mm.
may be tied to a clear anatomic problem. Sometimes you might not be able to identify anything anatomic. I'm sure you have both those kinds of patients. And then the history of what's been done for that pain, in terms of have they been on opioids for decades, in which case it might not be possible or always a good idea to try to get them off opioids entirely. Have they been on, what other medications have they tried through the years? So you're not always going back and recommending a medication that they tried 3 years ago and it didn't work at all, and they're going to get annoyed at you and frustrated, right?
Right.
What other things have they tried? If they are on opioids, all their opioid stewardship measures, the informed consent, the control, any problems from the controlled substance or prescription drug monitoring program, if they have naloxone, all the different things that you're supposed to do there. And then it's kind of set and it's all in one place in a note. That can serve a couple of roles. Both it can help to really, most of the providers that have had issues with prescribing opioids in terms of legal issues, it's been because they don't sufficiently their notes don't provide sufficient documentation for the opioids.
Hmm.
Patient came, refilled opioids is going to get you in trouble in the long run. So having a kind of detailed note can help to alleviate some of the concerns that some providers have.
Again, the time issue.
I know. The nice thing about a note like that, though, is it's mostly a one-time thing, and then you're just updating it on visits, as opposed to other things. I want to show you also a little bit. This is another document that we have in the form of we will have in the form of a poster. And this is from the AHRQ, Agency for Healthcare Research and Quality, that reviewed the data for these different interventions on different pain types. So another nice way to help direct patients who are, let's say they have, chronic neck pain. What are the interventions that have some data for them? I think that's been useful for some providers. Anything I'm showing you resonating at all? I know you're having some concerns about time on all of this.
I mean, to be honest, I sort of like the idea of bringing patients back in to spend a little more time talking just about pain. It'll bring in. We'll be able to bill for those visits. It's something that'll fly with my administration, and I wonder if patients would like it. So that's sort of that's a new thought for me.
Okay, great. There's a lot of other material that we can review if you'd like to at a future time. But for example, going over some of the ways that you can manage patients that are on opioids, reviewing, going over all your baseline assessments and things like that. But I do want to respect your time. We're at our 10-minute mark. I'd like to talk to you again, but between now and then, is there anything that you think you might do from our discussion today?
I may just see if patients would be up for separating out the pain management conversation from their usual healthcare maintenance or diabetes management or whatever. So yeah, I'm gonna try that on for size, and I can report back if it's a big flop or if it helps. I imagine it might help some patients.
So I'll set up a time with your receptionist to talk again, if that's okay.
Oh, sure. Yeah.
And thanks for meeting with me today, Rebecca. I enjoyed talking with you, and it's great to hear a little bit about your practice.
Thanks for taking the time. Have a good one.
You too.
And cut. So for those of you who have seen us do these before, chronic pain, I like to play the primary care provider that I have worked with countless times that just doesn't necessarily have the time or energy to spend 10 minutes out of a 15-minute visit actually checking in about patients' function, checking in with what hasn't been tried. There's a lot of providers that don't even have on their radar that patients could totally benefit from a more extended conversation about pain's impact on their life and maybe what they want to see different. So I appreciated that Dr. Coffin really was collaborating with me and not necessarily making me feel bad that I just have a lot of patients on opioids. I felt like the open-ended questions there helped me open up. They achieved their purpose. And yeah, I gave him a little bit of an ambivalent provider. How'd that session feel on your end, Philip?
Tough. That was a tough session. And, I think I made some missteps. I tried to jam some chronic pain knowledge and details at you that you weren't necessarily in the right place for. Whereas you did give me an opening, which was around that additional visit. I didn't have the materials to support it. And in the context of chronic pain, which is less my area of expertise, it's not my area of expertise. I feel a little bit less able to kind of jump on my feet to different domains. So I relied a little bit more heavily on my materials than I probably should have in this detailing visit. But I do think we got to a good place. And it's an important place for providers who are, particularly providers who don't have access to a pain expert referral clinic, because there's so much of there's not enough of those around the country, and so a lot of primary care providers are stuck managing pain on their own, and to not do a dedicated visit for that pain periodically is I think really a disservice to the condition that patients are facing. I'm curious if Antje has any thoughts about that interaction.
I thought that went great. I have a lot of primary care providers that tell me, well, I don't prescribe opioids. So I think that's a harder one to tackle because I think that's a naive statement to make, and so I'm on the other side where I'm not trying to say that opioids are first-line therapy, but there are some patients that really do well, and to again just say I'm going to stop. I was wondering if Rebecca was going to go that route with, I think I'm just going to stop and just taper all my patients, but she didn't go that route. So so we need to give our providers those tools to feel like they can, of course, prescribe opioids safely in appropriate instances, and also have those conversations, which don't have to take that much longer. And I think the suggestion of having a separate visit when I do an opioid evaluation to make sure that my patients are checking off all the boxes that I need to do in order to say my documentation is accurate and everything's going safely, it does take a full visit. So to add on another discussion about what else you can do for pain besides opioids is hard to do. So I think giving providers that opportunity to be thinking about the two separate visits was a really clever one, because there's not enough time in primary care visits. So I thought it went really well, and I'm surprised that, that Rebecca didn't, again, just sort of say, well, I don't know, this is too much for me. So finding that little hook was perfect.
Well, and all of these sort of demonstration sessions just go to show that we're not always going to, when we're doing detailing, we don't always have expertise in the exact topic or approach that comes up from a provider. So, you know, Philip, as an addiction medicine, infectious disease clinician, coming in to have the conversation with a provider who's a little nonchalant and maybe a little loose with opioid prescribing, you know, that's a set of skills and conversation topics, communication techniques that he might not feel he has to the extent that he wants them, but you can still make progress in connecting with the provider, helping them to feel supported, like you're advocating for them and trying to identify tools for them to have a more rewarding practice and support their patients better. There's lots of opportunity, even in those moments where we don't feel like we're the expert. So I just wanted to point that out as well.
I like the idea of those smart phrases that I think Dr. Coffin was referencing, is that sometimes me as a provider, I just want a checklist that I can easily integrate into my progress notes, and that's a great way to induce change and behavioral change in a provider, is give them a multi-dimensional pain smart phrase. So for instance, that you have medications, topicals, you know, alternative therapies, interventions, and just give them those categories in the pain wheel so that they know, oh, I need to ask that question. Have they tried this? Or around opioids, you're in drug screen, medication agreement, all those sorts of aspects of opioid stewardship that are really important. It's hard to remember them all, but when they're in the sort of package, I think that makes it much easier. And you can just say, here it is. You can copy and paste this into your note.
I do have a question, Dr. Barveld. Under what circumstances do you feel it's appropriate to be prescribing opioids for chronic, non-malignant, non-end-of-life pain?
What circumstances is there?
Yeah, and I know that's a complex question, and I think it's really interesting. It's something that I've been, you know, that I think about regularly on a clinical basis and in the context of the work we do here. And it's complicated and it's very individualized, obviously. But I'm just curious if there are some generalities in which you feel more comfortable in that domain.
In generalities, I think when starting a new opioid, I think very critically about that decision. I would say in pain management, I have not started or recommended starting opioid therapy for more than a handful of patients in the last few years, because I do feel that there are so many other things that we can do. Who are those patients? I think those with sort of debilitating chronic disease, severely progressive osteoarthritis, complications after surgery, and less so the kind of more complex centrally mediated pain syndromes. So that might be circumstances where I might be thinking about it, but it is weighing the risks and the benefits. And also I need to align with the primary care providers. I can't be prescribing opioids for everybody in the world because people don't want to anymore. So I do And then you want to risk stratify your patients. Who are those that you might be concerned about? Are they co-prescribed benzodiazepines? Are they on muscle relaxants? Are they, how are they in regards to mental function? Are there cognitive issues, balance issues, things that I need to be worried about where the medications could potentially be a challenge? Or even something as simple as chronic constipation can be debilitating. So if someone has some underlying GI issues or has chronic constipation, starting opioids may not be a great idea. So yes, it is a complicated question, and there isn't an algorithm. It's not, okay, you failed everything, so this is all we have. It's also understanding the patient and then doing a trial. So you try it out, and if it helps, great. But we're not going to be on this. We talk with the patient and individualize it with them, that we're not just going to keep escalating until we get sort of 100% pain relief. What are your functional goals? What are the things that you can't do? Well, I can't go shopping. I can't even leave my house because the pain is so bad. So then we can use the opioids to make sure we can get you out of the house and doing those things. And then a month or two later, I will look at, tell me about your activities. What have you been doing? And are the opioids causing any side effects? And are they getting you to those functional goals? And at the same time, always monitoring for any potential for misuse or euphoria or other things that the patient may be experiencing that could be concerning. Most of the time, patients who take an opioid don't get addicted. We forget that sometimes.
I know I put you on
Okay.
the spot with that.
Yeah.
And that was great. That was really helpful. The other side of that, of course, is the patients that are already on opioids and have been on for opioids for a long time. I'm curious what your thoughts are on the management of patients on long-term opioids when you first see them.
That's where I think you start with the best practices, make sure that everything's being done to keep your patients safe, not only to protect them, but also I think so that the prescriber feels that they're doing the right thing. And then it's looking at how they are doing on a day-to-day basis. And if someone is not doing well despite opioids or even perhaps high-dose opioids, are we doing something that might be harmful? Are opioids affecting their mood? What about their sexual function, other aspects of their life, things that patients don't always think about? I have patients that tell me, well, I didn't realize how irritable the medications made me until I started to come down on the medications, or my depression actually got better. So there's lots of other things. And I think when you bring up sexual dysfunction, a lot of people start to get a little more interested in what it's going to affect my sex hormones. So I look at function. If someone's doing well, there's no reason that we have to adjust the medication. I might ask the patient, what are your goals with the medication? Oh, things are going great. I don't want to do anything differently. There might not be any reason to do anything differently. Would I today start opioids in the same patient? Probably not. However, there's no reason for me to tell them they need to go off or down on their opioids unless I feel like, again, there are side effects or, of course, any other concerning findings, then yes. But we don't need to blanket taper everyone who has been kind of, I would say, our legacy chronic pain patients prescribed opioids. And I think we do a disservice to them as well by enforcing some of these recommendations and, again, state mandates. I know the state of Maine, they had once said that anybody prescribed over, I think, 90 morphine milligram equivalents had to be tapered. Fortunately, that went away after a few months because that really was irresponsible and not clinically indicated. Have we overprescribed opioids over the years? Absolutely. But we don't have to taper everybody.
Yeah, and I think that was a pretty clear misunderstanding of the CDC guidelines, misinterpretation of the CDC guidelines that the CDC tried to correct a few years back in a New England Journal article, and the FDA also tried to address in a press release that the guidelines, the CDC, their sort of dose cutoffs were intended for people being escalated on opioids, not as cutoffs for people who are already on higher doses. So that's been a real challenge, and I believe the CDC Injury Center is now is still working on developing guidelines to help those patients who are already on opioids in terms of what is the best practices for managing them, because it is qualitatively different experience than a decision to start opioids in somebody who was previously naive to those medications.
Absolutely, and I believe we put through different pain societies. We put in comments to the CDC where they're doing a whole new, I think, approach and revision to those guidelines, which were grossly misinterpreted.
I want to make sure before we wrap up, just to give folks an opportunity to put any last questions in the chat. And there was a question that came through from April, if academic detailing, is academic detailing allowed to be conducted virtually due to COVID restrictions? And there's some great conversation that happened in the chat. I think my brief response to that is it's not only that it's allowed, it's also that it is really beneficial for a lot of providers right now who are sort of just barely making it through a stressful year. It can be convenient for the provider. And actually it used to be used, e-detailing used to be done even prior to the pandemic to connect with providers in more remote areas. So from our team with CIAO, sort of part of why we did the little demo for all of you is e-detailing is totally feasible, and it just takes a little bit of finessing how you're going to be sharing your screen, trying to still simulate a face-to-face conversation with the provider and make it not just another Zoom meeting that a provider has to go to, but more of an interactive, hopefully fun conversation that a provider can really get something out of. So we have a lot of resources that we've developed around e-detailing, and would love to hear from any of you who are interested in expanding your e-detailing practice. Any other final questions? We're right about out of time. You can also always email us. I'm not going to recall the exact email, our regular CIAO email, but it is up on our website, and maybe Claire or Brian, if you could put the email into the chat in case anyone has any final questions. But thanks so much for being here with us. Thank you so much to Dr. Barveld for taking the time to share and enlighten us with laying some foundation for chronic pain management. It's much appreciated.
Thanks for having me.
Thanks, everyone.
Thank
As
you.
Rebecca always says, ciao for now.
Ciao for now.
Rebecca, do you want me to hang on for a debrief, or are you good?
Sure.
Yeah, but
Folks will trickle off. Let's see. Bye, Sandra. CADs you later. That's another good one.
I like that. It's funny.
All right, so we have a couple more people. Maybe I'm just going to
You move them back into
remove or put them back in the waiting room. Yeah.
That's the nice way of putting it.
Okay. I was like, I don't know if it's savvy to just remove somebody from the webinar, but all right. How'd that go? Besides our little polling mishaps, was it just, Claire, like a lag time?
So the first one I clicked, it popped up fairly quickly. The second one took longer, and the third took even longer. So I don't even know what that was about.
Good thing
Yeah.
we didn't have a fourth.
I know. I just kept pressing launch, and it was just taking its sweet time. So apologies for that. I don't know why that happened.
Okay. That's okay. That's why we have co-hosts.
I don't think it mattered.
No, just may have cut down your time by 30 seconds total.
Timing seemed good and didn't seem too long.
Yeah.
And it was a good introduction to people.
I think we should steal your OPQRST thing.
There's a couple longer mnemonics, but I just found that's the one we learned that in medical school, Phil.
Yeah, sure.
That's what I stole from UCSF, but I find that it's the simplest one.
Yeah, I feel like we should steal that for the book.
I like that idea.
Yeah, that was great. It was really wonderful. It was wonderful to, like, Bob Brody would be so happy that that we had you talk and that we focused on this. Bob being the guy at the pain clinic at the General, who always harangues me for, always says that this isn't about pain, this is about opioids, and you need to talk about pain. And I'm like, yeah, I know. And finally, I feel like we did.
Yeah, it's the same thing in medical school. We talk only about it. Well, the main focus is addiction, prevention, and treatment, but not how you actually manage pain. And so it's, sort of missing the point that pain is so pervasive. And if you're just afraid of opioids and you don't offer patients anything else, then you're not really practicing medicine.
Yeah, exactly. So that this was wonderful for me. I really enjoyed it. And I like being challenged on a detailing session.
Yeah, that was great.
And we had heard back, this is a smaller showing of participants. We heard back from CDPH that this is like everybody's vacation week this week. So just wanted to thank you for bringing this material, even like right at the beginning of summer. It's been sort of I don't know if I'd call it a gap, but it's been an area that we've wanted strengthened for a long time. So I'm just really thrilled for the folks who do detailing who are on this webinar, who will now have some more resources to get to share with their providers, because it's one of those topics that makes at least a lot of the people we've trained like totally go white in the face. Like, I don't know how to talk about chronic pain. I'm not a provider.
Brian, I wonder if any of this could be useful for one of the modules. I don't think it was. I think there was like a general chronic pain one, but there might be a way for us to sort of modify it a little bit or something, because the work's already done.
Yeah, absolutely.
I know that there were some other topics like opioid tapering, et cetera, but it might be a reasonable introduction to pain management. Maybe a little. I don't think you need that much more about opioids, because that's its own module.
Yeah, exactly.
So happy to have you modify that for any of it, if that works with the topics. I'm not sure.
Great.
All right, excellent. Well, thanks everyone.
Thanks everybody. Great job.
All right.
All right, have lots of fun out there. How's the weather in San Francisco?
Nice.
Sunny and 60, kind of cold. How's it in Boston?
Muggy and 90 degrees.
Oh.
I had to turn the air conditioning off in this room because it's too loud, so it's getting a little warm in here.
16. All right.
All right, thank you.
You're welcome back anytime, aren't you?
Oh, good. Happy to be back. All right, bye, everyone.
Thanks all. Bye.